thank the East Delhi Gynecological Forum, Shada Jahan ma'am, for allowing me to be here today afternoon, to be among this August gathering, I would say, and I'm very happy to be here today. The purpose was, as the breast lump would normally approach a gynecologist, either we can leave it and say that a surgeon should see a breast lump and they should go to a surgeon and all this, rather than we should respect what a patient thinks. If they want to go to a gynecologist, let's be prepared when a patient of a breast lump walks into your clinic and he presents you with a breast lump. So with the basic statistics first, the breast cancer is increasing and it is bound to be increasing in the coming months and years, because as we develop more, the chances of breast cancer goes on increasing. It is more in developed society as compared to the underprivileged and the underdeveloped society. Cervix cancer on the other hand is opposite. As we become more developed, the cervix cancer comes down, and in the underprivileged, the cervix cancer is more. So we have the two greatest killers in today, cervix cancer and breast cancer. Cervix cancer will go down with vaccination and as we become better, as far as our living conditions become better, and the breast cancer will go up from here. So the basic statistics is we have 1.8 lakh new breast cases every year, new breast cancer cases, 1.8 lakh. Around 75,000 of those will die. It is the most common cause of death as far as female malignancy is concerned. So if you get a breast cancer, the chances are 1 in 2 women will die out of it. So how do we do an assessment? The most common thing they are asked me, that I have a breast lump, what is the chances that I'll have a breast cancer, or what is the chances that somebody in my family had a breast cancer and I will be having. So this is a Gale model of assessment that we use. It is freely available online. I'm not going to detail into this because it is quite boring. The thing is that it increases with the age. The chances of breast cancer increases with age. It increases if you are a first degree relative or a second degree relative also to a breast cancer patient. If a prior breast biopsy has been done for breast atypia hyperplasia, the chances that the same female will get a breast cancer is higher. Again, age at menarche. If the female has an earlier onset of the periods in the menarche, the chances of breast cancer increases. The logic is simple. The breast cancer is associated with estrogen, and the earlier the female is exposed to estrogen, the chances of getting a breast cancer is higher. And for the very same reason, the chances of getting breast cancer are lesser when the female gets pregnant, because the hormones are suppressed. The earlier age of pregnancy, the more the lactational period, the hormone is suppressed for that amount of period, and the chances of getting a breast cancer are lower. Again, these are the risk factors. Coming to approach of breast lump, this is something which has not changed for last so many years. Triple assessment, all of us has been hearing for last so many years, and it is again a repetition of the same thing, but I'll try to make things clearer. I'll try to be concise and I'll finish it off quite clear. So the three things here are clinical examination, imaging, and the pathology. In pathology there are two lines there, FNAC and biopsy. The only thing I want to stress in this slide is that clinical examination is very important, imaging is very important. As far as biopsy is concerned, it should not be FNAC, it should only be a biopsy. Pathology should be biopsy only. Most of us still send for FNAC because it is convenient. You can just send to a pathologist and they'll do FNAC. But today we hope that we all come out of that zone. We'll be doing a practical demonstration of a biopsy. We'll have a hands-on also. We have a model of breast where you can all practice biopsies, and we try that you can learn the technique of biopsy and you can implicate that technique in your clinic, and that you can replicate it, and somehow you get more confidence. Probably not today, maybe another 1 or 2 sessions later, maybe you observe a biopsy being done and you can do it in your clinic itself. It is not difficult at all. It hardly takes 5 minutes. There is no complication associated with it. It's not a big procedure, it's a very small procedure. So we should come out of that shell and do biopsies ourselves. So this is a typical breast. So it is made up of, the normal anatomy would be ducts and lobules. So these are the two things we should remember. Adipose tissue is adipose tissue. The stroma consists of duct and lobules, and the junction of the duct and lobules are terminal duct lobular unit, is where the breast cancer normally arises. So the first thing is, when they come to you, a clinical breast examination, it consists of two parts: inspection. The first part is inspection, as we have been learning from our MBBS, to look at the breast and look at all the asymmetries, any nipple retraction, any changes in the skin overlying, or any other visual changes that you can see. Next comes is palpation. Palpation is done in 4 positions, but the normal positions that we use in our clinic is one is sitting and one is lying down. That's more than enough. So if you can examine the patient in 2 situations, is sitting and lying down, that is enough. In the sitting position, just inspect if the breast is hanging normally, both the breast sides are normal. There is no tethering or puckering of the skin of the breast. The breast, one of the breast is not deformed as compared to the other one. That is normally what you will observe. You will also observe if there is a lump, if there is a skin change over the lump or anything. And as far as palpation is concerned, palpation is a very important thing. So how do we palpate a breast lump? We usually use these 3 fingers. The 3 fingers, not the little finger, not the thumb, the 3 fingers in between, and we use it from the pulp of 3 fingers. We don't poke a breast because it is very wrong to do that. Just use the pulp, gently feel the breast, and you go around the breast making circles. In a circular fashion, go around the breast trying to feel for a lump. You can use light pressure, just a small go through. When you go around, just try to feel any irregularity, and this is when you will feel most breast lump. So this one thing is light pressure is the one where you will feel most breast lump. Just go light, or maybe you need medium pressure. The last one, deep pressure, is hardly needed. Deep pressure is needed when you feel something and then you do give a deep pressure to assess that how much is the size of the lump. Again, next part is you observe for the lymph nodes in the axilla and the axillary tail of breast. So the warning sign, and would like to stress again, there is unusual increase or decrease in one breast size. There is puckering of the skin. There is swelling of the upper arm. There is milky or a bloody discharge. Bloody discharge is very ominous, and you should be looking for the bloody discharge. There is lump in the breast that can be felt on examination. These are the telltale signs of a thing that is not. A painless lump that has been growing in a female who is over the age of 40 or 50 cannot be ignored. Whatever the radiological findings are, whatever it is, 40, 50, a lump that is growing in size should not be ignored. Again, this is what it is. So when the patient is, this is from a latest article, how do you approach it? Is it 20 years of age, you see a breast lump, there is nothing needed to be done further. You need not biopsy, you need not, you might let it go if you think it's a fibroadenoma. Most of these lumps will be fibroadenoma. Less than 20, you should not do. 20 to 25 years, you do a clinical assessment, and the minimum is you get an ultrasound for everyone. You can't let it go. 20 to 25, the minimum is. Less than 20, you might leave them without an investigation, without imaging. Over 25, definitely ultrasound and mammogram after 35 years of age. After 30, again, you see, remove lump for all patients over 30. Over 30, all lumps have to be removed. At least over 40, all lumps have to be removed, irrespective of the imaging finding. So that is the implication. Even if they say it's a fibroadenoma over age of 30, 35, 40 years, take it with a pinch of salt. It's not fibroadenoma most of the time. And even if it is fibroadenoma and you remove it, it hardly matters. You have removed something which could, which we masquerading the malignancy. Again, the size is very important, ma'am. The size is when the patient notices, the size is usually around 2 centimeters when the patient will notice. The normal patient, when they come with a breast lump, you would be around 2 centimeters when they come to you, more than 2 centimeters. If you find it by clinical breast examination, it might be 1 centimeter. Again, size is not very important. I have seen breast cancer as small as 1 centimeter, 0.5 centimeters, so it is not important. Anything above the age of 30, any lump in a female above the age of 30, 35 has to be removed. Even it is 1 centimeter, even if it is a fibroadenoma, everything above 30 should be out. Again, BI-RADS, we all know BI-RADS, right? Breast imaging, reporting, assessment and data system. It has been there for many years. Again, can anybody tell me what is BI-RADS 0? Inconclusive. Very good, ma'am. Everybody is more intelligent than me, I would say. So BI-RADS, I know. BI-RADS 0 is, yeah, I am absolutely sure. She taught me well also. So BI-RADS 0 is inconclusive, you need another investigation. And BI-RADS 6 is, you have a FNAC. Only 3 things we need to know. BI-RADS 0 reimaging, BI-RADS 3 is somewhere where you can keep a patient under follow-up, and anything above BI-RADS 3 has to be removed. BI-RADS 4 and 5, there is nothing, it has to be approached surgically. and it has to be removed. BI-RADS 4 is coming out. BI-RADS 3 is close follow-up. Now there is a catch in BI-RADS 3. If there is a family history of breast cancer and there is BI-RADS 3, if there are other risk features like smoking, early onset of menarche, and you have a high index of suspicion, you remove it. Again, the patient is from a rural background, comes from a distant place, can't come to you again, you remove it. So this is more like it. Again, BI-RADS 4 has got 3 classes, A, B and C. BI-RADS C has a chance of 50 to 95%. BI-RADS B has 10 to 50, and BI-RADS 4A has less than 10%. So this is also important, that BI-RADS 4C is again almost like BI-RADS 5 only. So 4C is important. So this is the size of breast lump. When you will diagnose it, 0.5 is when a highly skilled clinician who has been examining breast for a long time will be able to diagnose this. 1 centimeter is a normal clinician when they examine a breast will be able to diagnose this. 2 centimeter is when a patient with a breast self-examination will diagnose this. So most of the size would be 2 centimeter and above when the patient comes to you. So next thing is mammography. Okay. So what is a mammogram? It says X-ray of a breast, simple X-ray of a breast with a low dose X-ray, which has got 2 views, MLO and CC. MLO is medial lateral oblique and CC is craniocaudal. So there will always be a marking CC and MLO. These are CC views. The breast is put horizontally. This is a CC. Breast is obliquely viewed. This is medial to lateral MLO view. So diagnostic mammogram is when you have not seen a breast lump and you want to diagnose it, or a screening. Okay, that's a diagnostic or a screening. Or you want to characterize, if you have seen a lump and you want to characterize that lump, what is the BI-RADS of that lump. So this is a very small example. For example, this calcification here, this is a coarse calcification. Okay, this is a fibroadenoma. I am not really worried when I see this calcification. I know this is a fibroadenoma, and the chances of malignancies are almost next to nil. On the other hand, you see a lump which has a spiculated appearance, where the there is poking into the breast, and it has got some calcification there, very subtle calcification. This is definitely a bad breast lump which has to come out. Coming to the tissue diagnosis, there are 2 things. What should you do, core cut or FNAC? It's obviously biopsy is better than FNAC. And whether you should do ultrasound or clinician should do in his office. So I always believe the breast lump is big enough, and finally you are going to do surgery, you can put the incision which will be taken out surgically, because the incision site should be removed surgically whenever you are doing an excision of the breast lump. So try to do it in your office yourself, don't send to a radiologist. What is a core biopsy? Core biopsy needle is there on the back. You will all have a chance to see it. It has a needle that goes inside, and there is that is the core, and from above the sheath comes. The sheath will cut the tissue, and the tissue will be trapped inside the needle. You will have a long core of tissue that a pathologist can see. So final diagnosis will be made on 3 things: clinical examination, core biopsy and mammogram, and this is up to 95% that you will be able to give a correct diagnosis. 95 to 99%, up to 99% is various literature says if you have done 3 things you will have a diagnosis. Again, coming to the staging workup or a metastatic workup, so we sometimes request MRI of the breast. So why MRI? MRI we request where we have a dense breast, that a small lump can be missed in that dense breast, or there is a strong family history, we want to screen the breast more carefully. So we might request an MRI, or we are doing a breast conservation surgery and we have a suspicion that there might be a second lump that should not be missed, we might request MRI. As far as metastatic workup is concerned, early breast cancer, there is only 2 things is required: chest X-ray and ultrasound of the abdomen. But most of the time patient will get a PET CT done, because it is a relatively inexpensive investigation in our country. For 10,000, 8,000 you can get a PET CT done. So most of the patients will end up getting PET CT, and because it gives information about bone, other visceral organs, we have a great deal of information that we can keep. It also helps us to reduce the chances of missing a concurrent synchronous second malignancy. For example, there might be an ovarian lump that we might have been missed on ultrasound. There might be endometrial thickness which might be missed on abdominal ultrasound, a subtle abdominal endometrial thickness. So this kind of a PET CT We usually do not refuse patient when they ask us whether we can get a PET CT. In fact, we sometimes offer them that a metastatic workup has not been done, go and get a PET CT done. Again, the factors that will influence is age. Age is, the younger the age, worse. It's worse because the chances of having a triple negative breast cancer are higher. Again, tumor size, the more the size, the chances of metastasis are higher. Stage at diagnosis, from the PET CT, you will know whether the lymph nodes are involved or not. Again, hormone receptor status, ERPR and HER2/neu. This is the most important thing. A triple negative breast cancer has a least favorable chance of survival. Stages of breast cancer will be tumor size, nodal status and metastatic as in all cancers. And this will be, when you see the size, it is less than 2 centimeter, 5 centimeters or more than 5 centimeters. In stage, I don't want you to remember everything. Stage 1 is a small breast cancer. Stage 2 is a small breast cancer which is localized to the breast or has spread to a single lymph node in the axilla. Stage 3 would be advanced breast cancer and above. Stage 3 is when multiple axillary lymph nodes are involved. So, if a patient comes with axillary lymph node, you can easily say it's a stage 3 cancer. And stage 4 is when other organs are involved. Coming to the treatment, there are only two treatments. As far as surgery is concerned, as you remove the complete breast, it's a modified radical mastectomy or you will do a breast conservation surgery. As far as addressing the axilla is concerned, you can do an axillary lymph node dissection or you can do a sentinel lymph node dissection to reduce the chance of lymphedema. There are other two treatment options, which is medical oncology, obviously the systemic treatment, and another local treatment which is radiation oncology, which Madam Dr. Miolia and Dr. Rashmi would be speaking in detail. So, this is one complication of surgery, lymphedema, which is a very debilitating complication. So, what we do is we do a sentinel lymph node dissection if the lymph nodes are not involved. Unfortunately, if the lymph nodes are involved, we have to do a axillary lymph node dissection. So, last slide about the myths of the breast cancer. This is important because I always want to speak about this. I see a lot of patients talking about this. Whenever I see a young girl, recently I had a young girl in my office. She was a friend of mine, 30 years of age, 33 years of age. She had a breast cancer. She had a small child. She was crying that it is deadly. I'll not be able to take care of my child. That's a myth. It's not deadly. It's completely curable. Very small now, less than 1.5. No axillary lymph nodes on MRI or staging. And again, no metastasis on PET CT. Very curable cancer. The chances of her being alive are more than 80-90% after 5 years. It cannot be prevented. It can be prevented. It's a preventable disease, and sooner or later we'll have the complete picture how we can prevent it. As far as now is concerned, it is family history. We should be looking at family history. If there is a strong family history, we should be screening these patients. We should maintain a healthy lifestyle. We all know that. That's a preventable. It spreads after biopsy. This is one myth which I want all of you to tell to your patient. It doesn't spread after biopsy. Nobody wants a needle in their breast lump. They just want it removed. I mean 90% of the patient will tell me after a needle it will spread, and I have to convince them no, it doesn't spread after a needle. Nothing will happen. You can easily get a biopsy done. It's an office procedure, and everybody in this world will get a biopsy done for the treatment of breast cancer normally if they go by a doctor's advice. Breast has to be removed. My breast conservation surgery rates are 70-75%, so only 25% of MRM, which is as good as what is mentioned in the literature. If we can save breast in 75% of the females, look at the psychological impact that we are having on the health of a female, and if we cannot save, we should be able to offer them reconstruction at the very same setting. Too much emphasis is being laid on the side effects of chemotherapy and radiation, which is not the case. I have seen almost all patients taking medical oncology and chemotherapy very easily, no issues. I have seen madam patient, they tolerate very nicely. I see minimal side effects which are very much acceptable, and patient should not be afraid of chemotherapy and radiation. Thank you. That's all I want to say.